Welcome back guys. Now in this video let's discuss about cellular adaptations. Okay, cellular adaptations. In the name itself it's there, cells are getting adapted. Okay, the cells whatever were there, they are getting adapted, cellular adaptations. Now why the cells are getting adapted? Cells are adapting to what? The cells are adapting to stress. Okay, cells are adapting to stress. So adaptation to what? Stress. So whenever I give you stress, for example as a teacher, whenever I ask you to do so much work, so much homework, okay, so what you will do? Usually beyond your limits you will try to do it. Okay, so okay, you will adjust your time, you will try to do the work, you will adjust, you will adapt, right? So in the same way, whenever there is some stress to the cells, even cells will try to adapt. So that adaptation of the cells for stress is called as cellular adaptation. Okay, when you are giving more and more stress to the cells, in order to prevent the damage, in order to prevent the cellular injury, in order to prevent the cell death, first they will try to adapt to the environment. Okay, so that process is called as cellular adaptations. Now in this video we are going to discuss about different types of cellular adaptations. The first cellular adaptation is called as hypertrophy. Okay, hypertrophy, in the name itself it's there, hyper means big, hypertrophy. Okay, hypertrophy, the cells are getting bigger in size. Hypertrophy means increase in cell size. Okay, so increase in the cell size. A cell is becoming big in size. Now why a cell is getting bigger in size? Because of what? Because of what mechanism? What exactly is happening in that cell so that it is getting bigger in size? The hypertrophy is because of increase in the protein synthesis within the cell. The number of proteins are getting increased, so the cell is getting bigger in size. So hypertrophy is due to increase in amount of protein synthesis. Okay, it's because of the increase in the amount of protein synthesis. Now in hypertrophy, what changes are seen at the molecular level? See, in a cell which is undergoing hypertrophy, there is increase in transcriptional factors. See, you know, right, transcription is the one, translation is the one which is involved in the production of the protein synthesis. So the transcriptional factors, those factors which are involved in the process of transcription followed by translation, protein synthesis, so those factors are increase in the transcriptional factors. So what are the examples of those transcriptional factors which are increased in a cell which is undergoing hypertrophy? So it's a GAT4. Okay, so GAT4, okay, GATA4, you can say GATA4 is increased, and NFAT increased, and MEF2. Okay, MEF2 levels. See, all these are the transcriptional factors, their levels are going to be elevated. Now you can ask me, sir, in hypertrophy you have said a small cell is becoming bigger in size, a big size cell. This is the hypertrophy. Where we can see such example? Okay, hypertrophy is seen in which conditions? Examples are important. Seen in exercise. Okay, whenever you do exercise, you know it, whenever you go for the gym and whenever you try to do the workouts, when you lift the dumbbells, what happened to the muscle size? Muscle size is getting bigger in size. Okay, the muscle is getting bulkier. So what exactly is happening in those myocytes? What exactly is happening in those myofibers? Is more protein synthesis. So the cell size is bulging, getting bigger in size. So exercise will increase the size of muscles. So there is muscular hypertrophy. Next, this is one example. Second example is outflow tract obstruction. Outflow tract obstruction. For example, say imagine there is this gland, or you can say that's a bladder or something. For example, gallbladder, urinary bladder, something. See, there is obstruction over here because of some stone. Okay, there is obstruction. Now what happens, in order to send this fluid or send the secretions out, okay, in order to send the secretions out from the gland, out from the urinary bladder into the duct, okay, what happens is there will be more hypertrophy, okay, there is more hypertrophy of the muscles. So, the muscle which is surrounding the bladder, the detrusor muscle, it will undergo hypertrophy in order to empty the bladder, because there is obstruction, right. So, you have to powerfully send the secretions or the fluid out of the gland or bladder. So, whenever there is a outflow tract obstruction, automatically the size of the muscle which is surrounding the gland or bladder or something is going to be increased. Next, sir, in breast during puberty as well as pregnancy, okay, during puberty and pregnancy, what happens? Breast size increases, no doubt. So, the size of the breast is increasing. Now, why the breast size is increasing? See, both hypertrophy will happen as well as hyperplasia. Okay, in the puberty and pregnancy, the breast size is increasing. The breast size is increasing both because of hyperplasia as well as hypertrophy, both are happening, but hyperplasia is more. Okay, so in the breast, hyperplasia is more than hypertrophy. Even hypertrophy is happening, but hyperplasia is predominant, which is involved, which is the one responsible for increasing the breast size. Okay. Now, uterus. If you talk about the uterus, same. The uterine size increases with age, from a child to the puberty and reproductive age, the uterus size is getting increased. So, puberty as well as pregnancy, the uterus size increases, no doubt, but mainly because of hypertrophy. Hypertrophy is more than hyperplasia. Here also both hypertrophy happens as well as hyperplasia happens, but hypertrophy is more predominant. So, what I am saying, hypertrophy is more predominant than hyperplasia in uterus during puberty as well as pregnancy. So, with this what we have completed? We have completed about the hypertrophy. The examples of hypertrophy are seen in the exercising muscles. If there is any obstruction, outflow tract obstruction, definitely you can see the hypertrophy of the muscles, as well as in puberty and pregnancy the breast size increases and uterine size increases. In the breast, hyperplasia is more predominant, in the uterus hypertrophy is more predominant, but both hyperplasia and hypertrophy happens. So, during hypertrophy, or I should say the hypertrophy is because of increase in the amount of protein synthesis. What happened to the transcriptional factors? The transcriptional factors are going to be increased. Which transcriptional factors? CATA4, MEF2 as well as NFAT. These are the transcription factors. Now, after this, let's discuss about second type of cellular adaptation, that is hyperplasia. Okay, hyperplasia. So, what exactly is hyperplasia? If you ask me, increase in cell number. So, cell number is increasing, the number of the cells. For example, from one cell, it is going to become multiple cells. Okay, one cell is dividing and forming many number of cells. So, this is called as hyperplasia. Now, example. Okay, see, where you can see this hyperplasia. Hyperplasia is seen in which conditions? Yes, cell number is increasing. But where, sir? In which examples? Let's take a tumor, sir. There is a tumor called as granulosa cell tumor. Now you will get it out, sir. Where exactly are these granulosa cells present? What is this granulosa cell tumor? Now, if you take a female ovary, inside the female ovary, what do you have? You are having multiple eggs, right? The follicles are there. See, these are the oocytes, for example. See, these are the oocytes. These oocytes are surrounded by cells. These oocytes are surrounded by certain cells, these blue color cells. Together with the cells, these are called as the follicles. So, these blue color cells are called as the granulosa cells. So, granulosa cells are present around the oocytes, or you can say granulosa cells are present in the follicles. Now, these granulosa cells normally they produces the estrogens. Okay, they produces the estrogens in the female. Okay, when you have tumor to those cells, the granulosa cell tumor, now what do you have? More amount of estrogens, lots and lots of estrogens are going to be produced. So, what I want you to know is, in the granulosa cell tumor, in these conditions, the female is going to have estrogens, but too much amount of estrogens. So, I can say hyperestrogenism or hyperestrogenic states. So the female is now hyperestrogenic. Now what happens? So this estrogen, where it will go? The estrogen is going to go to the uterus. Now in the uterus, the estrogen is going to stimulate the endometrial lining. For endometrium, okay, you know right? See, within the uterus, there is a lining which is called as endometrium. For this endometrium, what is the stimulation? What is the food? Food is nothing but the estrogen. So, where this female is having lots and lots of estrogen, it's going to stimulate the endometrium within the uterus. Endometrium within the uterus. Not the uterine smooth muscle, not the smooth muscle of the uterus. It's the endometrium of the uterus. So, let me write here uterine endometrium. So, that uterine endometrium under the influence of this estrogen is going to divide, becoming hyperplasia. So, there will be endometrial hyperplasia. Okay. So, this endometrial hyperplasia, it's actually a precancerous stage. Okay. Because there is so much stimulation coming. Okay. There is so much stimulation coming. First, there will be endometrial hyperplasia. Later, this endometrial hyperplasia can even turn into cancer. Okay. It's actually a precancerous stage. Okay. So, usually speaking, generally speaking, hyperplasia, it increases the risk of cancer. It increases the risk for cancer. It's a precancerous stage. It's considered as a precancerous stage. But there is one hyperplasia in the body, okay, one hyperplasia in the body which will not increases the risk for any cancer. What is that hyperplasia, sir? So, that hyperplasia is called as BPH. BPH stands for benign prostatic hyperplasia. Okay, benign prostatic hyperplasia, BPH. Sir, in this benign prostatic hyperplasia, there is no risk for cancer. It happens in the males, okay, usually in the older males because of the dihydrotestosterone, high levels of dihydrotestosterone levels, there will be hyperplasia of the prostate. So, this benign hyperplasia of the prostate, there is no risk of cancer. Okay, there is no increased risk for the cancer. It's not a cancerous condition. So, let me put one important point here. Say testosterone in the males will be converted into 5-DHT, dihydrotestosterone, with the help of an enzyme called as 5-alpha reductase. So, this 5-alpha reductase is the one which is converting the testosterone into more potent form, that is the 5-dihydrotestosterone. So, this dihydrotestosterone is responsible for the hyperplasia of prostate. Okay, it's the one responsible for the hyperplasia of prostate. Now, what we have to do? We have to inhibit this enzyme. We have to inhibit this enzyme so that the testosterone is not converted into dihydrotestosterone and the prostate is not going to become bigger in size. So, benign prostatic hyperplasia will not occur. See, if the patient is having benign prostatic hyperplasia, he is going to have problem with the urination. Okay, difficulty in the urination. If he feels like he is having the the urge for the urination. Whenever he go for the urination, urine is not coming out because the urethra is getting compressed. Because of the prostate around the urethra, see, there is prostatic hyperplasia, benign prostatic hyperplasia. So, because of the bigger size prostate, it is going to compress the urethra. So, he will be having difficulty in the urination. Dysuria will be seen. So, what we have to do? We have to inhibit this enzyme. How can we inhibit this enzyme? With the help of drugs like finasteride and dutasteride. Okay. So, finasteride, dutasteride, these are the drugs which are 5-alpha reductase inhibitors, okay, which are used in the treatment of benign prostatic hyperplasia, which should not increase the risk for cancer. Now, after this, see, 2 adaptations are completed, hypertrophy completed, hyperplasia completed. Now, the third adaptation is atrophy. Okay, atrophy. So, what exactly is atrophy? See, the size of the organ, if it is getting decreased, okay, from bigger size, if the size of the organ, if it is becoming smaller in size, the volume is getting decreased, that is called as atrophy. So, size of the tissue decreases. The size of the tissue is decreasing. Why the size of the tissue is decreasing? Size of the tissue is decreasing. Tissues are made up of what? Tissues are made up of cells. Okay, the tissues are made up of cells. So, what we are discussing? We are discussing about the atrophy. I have explained you atrophy. What exactly is atrophy? Atrophy is the decrease in the size of the tissues. The size of the tissues is getting decreased. Why the size of the tissues are getting decreased? I have explained you that tissues are made up of cells already. Okay, the tissues are made up of the cells. So, whether the cell size is decreasing or whether the cell number is decreasing in atrophy. See, in atrophy, cell size, the size of the cells is decreasing as well as the number. So, number of the cells are decreasing as well as the size of the cells are decreasing. Both are decreasing. So, size and number of the cells decreases. So that the organ size, the tissue size is getting reduced. Now, my question is atrophy. What is the mechanism? What is the mechanism involved in the atrophy? The mechanism is ubiquitin proteasome degradation. Okay. So, ubiquitin proteasome degradation. So, whatever the molecules which we do not require, okay, in the cell, whatever the molecules which we do not require in the cell, they are going to be targeted with the ubiquitin, they are going to be tagged with the ubiquitin. That ubiquitin tagged molecules, the ubiquitin tagged proteins will be directed to the proteasomes. In the proteasomes, those ubiquitin tagged molecules are going to be broken down. So, the cell size decreases, the proteins inside the cells decreases. So, the cellular size also decreases, the proteins inside the cell decreases, the size of the cells also decreases. Okay. So, what is the mechanism of atrophy? It is a ubiquitin proteasome degradation pathway. So, for example, for those students who doesn't understand, imagine this is a cell. Inside the cell, there is this protein present, which we don't want now, okay. So, you are not using the muscle. So, what happens? The size of the muscle decreases, right? Do you know what exactly is happening inside the muscle? So, the proteins, whatever were there, we don't want much proteins now. So, these proteins are going to be tagged with ubiquitin. Now, this ubiquitin tagged proteins, they will be directed to the organelle which is called as proteasome. So, inside this proteasome, this ubiquitin tagged molecules are recognized and they are going to be broken down. So, this is called as ubiquitin proteasome degradation pathway. Okay. So, where you will see such atrophy are seen in, one is wasting. So, wasting or disuse atrophy. For example, you are not using a muscle, okay, you are not using a muscle because of some reason, because of paralysis or because of stroke, because of some reason the person is not walking. When the person is not walking, what happens gradually with the time? The quadriceps muscles, the muscles in the legs will become smaller. So, he is going to have very thin limbs, thin extremities. So, whenever you don't use a muscle, it will become smaller in size. Whenever you use a muscle more, it will become bigger in size, hypertrophy. If you don't use it, atrophy. If you use it, hypertrophy. If you don't use it, atrophy. As simple as that. So, wasting or disuse atrophy. Next, malnutrition atrophy. Malnutrition atrophy. What exactly is malnutrition atrophy? See, you are using the muscles, but you are not giving proper nutrition. You are not properly feeding those muscles. So, they will undergo atrophy. So, malnutrition can be a cause of atrophy. Next, ischemic atrophy. Ischemic atrophy. You are using the muscles, you are giving the proper nutrition, everything is okay, but the blood supply to that muscle is lacking because of the thrombosis or some other reason. The blood supply is not enough. The patient is having maybe anemia. So, oxygen delivery to the tissues is not proper. So, there is ischemia to the tissues, which can lead to the atrophy possible. And the fourth type of atrophy is denervation atrophy. So, what exactly is this denervation atrophy? Your muscles, for example, say this is a muscle, this is a skeletal muscle. These muscles are innervated by the neurons, for example, the alpha motor neurons, the motor neurons. This is a neuromuscular junction. See, this is a motor neuron. Every muscle is innervated by a neuron, which will give the trophic nutrition. It will maintain the trophic nutrition and it keeps the muscle engaged, it keeps the muscle doing its work, everything is okay. But if this nerve is gone, denervation, we have because of some lesion, upper motor neuron lesions, lower motor neuron lesions, especially with the lower motor neuron lesions. If this lower motor neuron is damaged, Now this muscle, is it working? No, it's not working. Is it getting its proper nutrition from this nerve? No, it's not getting. The trophic action is not coming. Trophic stimulation is not coming. So this muscle can undergo atrophy, that is called as a denervation atrophy. Continue. So we have completed the 4 types of atrophies. What are they? Wasting atrophy, malnutrition atrophy, ischemic atrophy as well as denervation atrophy. So we have completed the 4 different types of atrophy. Now let's begin with the metaplasia. So what exactly is metaplasia? What exactly is happening here? See, in metaplasia, one cell type is going to change into other type of cell. Okay, one cell type is going to change into the other type of cell because of some stress. In order to encounter that stress, in order to adapt to that stress, one cell type is changing into other cell type. So this is called as metaplasia. Okay, stress is responsible for the conversion of one cell type into the other cell type. So what is the mechanism underlying? The mechanism underlying this metaplasia is MCQ. It is stem cell. Okay, stem cell reprogramming. Okay, it's a stem cell reprogramming. Due to the process of stem cell reprogramming, one cell type is changing into the other cell type. Okay. Now, where you will see or when you will see such metaplasia? Metaplasia is associated with which vitamin deficiency? See, this is the question asked. Vitamin A deficiency. Vitamin A deficiency. So, vitamin A deficiency is associated with metaplasia. Now, what are the examples of metaplasia? Where you will see metaplasia, in which conditions? First example is Barrett's esophagus. Barrett's esophagus. See, which is very much important for your exams. We will discuss about the Barrett's esophagus in a minute. See, Barrett's esophagus is an example. Second one, myositis ossificans. Okay, myositis ossificans. Next, smoker's lung. Smoker's lung. And the fourth example of metaplasia is mold or Zuska's disease, Zuska disease, which is seen in the breast, okay, which is seen in the breast, especially in the smoking females. So, the points which I want you to know is here, see, metaplasia is changing of one cell type into the other cell type, okay. It is because of the stem cell reprogramming. So, it is associated with which vitamin deficiency? Vitamin A deficiency. What are the examples of metaplasia? Barrett's esophagus, myositis ossificans, smoker's lung as well as Small's or Zuska's disease. Now, let us see one by one. See, in Barrett's esophagus, which is most important for the exams. See, in Barrett's esophagus, what exactly is happening? See, in Barrett's esophagus, see, if you see, this is the esophagus, okay. Here it is the gastroesophageal junction, the lower part is the gastroesophageal junction, here is the stomach. Now, let us say this is the stomach, sir. Here is the pyloric sphincter, okay, here is the stomach. Now, because of not proper tone, because of some damage or because of some, whatever the reason, okay. See, if this acid HCl, okay, if this acid, if it is regurgitating back into the esophagus, so what is happening? There is GERD, gastroesophageal reflux disease. Continue. So, there is gastroesophageal reflux disease, means the gastric acid is getting refluxed into the esophagus because of not proper tone in the lower esophageal sphincter. Yeah, the acid is getting regurgitated back. So, the patient is going to experience what? The pain, okay. So, pain after eating in the chest, there is going to be burning sensation in the chest region. So, that is the gastroesophageal reflux disease, okay. See, there is a proper lining, okay, there is a proper protection for the stomach from the acid. From the acid, there is a proper protection, mucosal protection for the stomach. But there is no such protection in the esophagus. See, esophagus is lined by which kind of epithelium? Squamous epithelium. Esophagus is having squamous epithelium, okay. Stratified squamous non-keratinized epithelium is seen in the esophagus. But in the stomach, what kind of epithelium is there? Columnar epithelium is there. See, columnar epithelium is a better epithelium for the acid. Columnar epithelium is a good kind of epithelium, okay. It's a better epithelium which can tolerate the stress, okay. So, what happens whenever there is this gastroesophageal reflux disease? Is the stress. Now, there is a stressful environment in the esophagus. Now, this acid is causing to cause damage to the esophagus. So now do you know what esophagus, what your esophagus is going to do? Your esophagus now going to convert, see, the squamous epithelium. So the squamous epithelium is going to convert into columnar epithelium. So in the lower one third of the esophagus, in this region, the lower one third of the esophagus, the squamous epithelium, whatever is there, that squamous epithelium is going to be converted into different type of epithelium. So one type of cell is getting converted into other type of cell. So which is an example of metaplasia. Okay. So not only columnar epithelium, but also it will develop the glands. That's the goblet cells. So what are the goblet cells? They are the mucus producing glands. Okay, they are the mucus producing glands. So what happened at the end of the day? The squamous epithelium is going to be changed into the columnar type of epithelium along with the goblet cells. So this type of metaplasia is called as intestinal type of columnar metaplasia. Okay, intestinal type of columnar metaplasia. Okay, so intestinal type of columnar metaplasia is seen. Why we are calling it as intestinal type? Why we are calling it as intestinal type? Because goblet cells are present in the intestine. Okay, goblet cells are present in the intestine, not in the stomach. In the stomach, yes, of course, columnar epithelium will be present, but not the goblet cells. So here, columnar epithelium is there along with the goblet cells is there, which is usually seen in the intestines. So intestinal type of columnar metaplasia is seen in Barrett's esophagus. Okay. Now the point which I want you to know is, see, acid is refluxing into the esophagus. Acid reflux is there. So there is metaplasia is seen. Okay, good. Metaplasia is seen. But still acid is refluxing back. Acid is refluxing back. So do you know what happens? So if I am giving you too much work, if I am giving you so much stress beyond your limits, at one point you will say, I am done with this. I could not take this much stress. I am done. I am going to just go away from you. In the same way, whenever there is so much stress, even this metaplasia can turn into cancer. So metaplasia, yes, it's a precancerous stage. You can consider it as a precancerous stage. Okay, if you continue the stress, it can turn into cancer, neoplasia. Metaplasia can turn into neoplasia. True. Okay, so what happens is, in the lower one third of the esophagus, whoever have Barrett's esophagus, okay, whoever have Barrett's esophagus in the lower one third, they can develop adenocarcinoma of what? Of esophagus. So what I want you to know is, this metaplasia is a precancerous stage. Metaplasia is seen in esophagus. That's the example, that is Barrett's esophagus, which can lead to adenocarcinoma of the esophagus in the lower one third. So what is the most common site of adenocarcinoma? The most common site of adenocarcinoma of the esophagus is lower one thirds. What is the precancerous stage for adenocarcinoma? It's a Barrett's esophagus. What type of metaplasia is seen in the Barrett's esophagus? Intestinal type of columnar metaplasia. Metaplasia is because of what? Vitamin A deficiency can cause it. Stem cell reprogramming is the mechanism underlying the metaplasia. Okay. So what exactly is myositis ossificans, if you ask me? See, whenever there is damage to the muscles, whenever there is a trauma, accident or something, okay, penetrating injury, something. So there is inflammation within the muscles, myositis. So sometimes what happens is, in that area where there is damage, inflammation, a bone kind of material, hard calcium, bone kind of material will develop. Means, so within the muscle is myocytes, where you are developing the ossification, osteoblasts will come, like bone like material is going to form. So in one type of tissue, other type of tissue is getting developed. In muscle, bone is getting developed. So that is myositis ossificans, usually seen with the trauma to the muscles. Okay. So that's also example of metaplasia. In smoker lung, what exactly happens? See, normally in the respiratory tract, what kind of epithelium is there? Ciliated columnar epithelium. Ciliated columnar epithelium is there. The cilia is there to remove the mucus, to remove the sputum, to remove the dust particles. So whoever is doing the smoking, the smoke is going to cause the damage to the respiratory lining. So the epithelial cells are going to convert from ciliated epithelium, ciliated columnar epithelium, to the squamous epithelium. Now they are becoming squamous epithelium. So it's a type of, which type of metaplasia? Squamous metaplasia. It's a type of squamous metaplasia, not columnar metaplasia. Columnar epithelium is converting into squamous epithelium, simple squamous epithelium. So, it's an example of squamous metaplasia, which is most common type of metaplasia. Okay, squamous metaplasias are most common. Squamous metaplasias are most common, seen in the smoker's lung. Okay, so these are the important points which I want you to know. Now, question is, whatever I have discussed, hypertrophy, hyperplasia, metaplasia, are they reversible? If you take out the stress, all cellular adaptations are reversible. Okay, see, so hypertrophy, hyperplasia, next metaplasia, all these are reversible. Okay, all of them are reversible, no doubt in that. If you take out the stress, cell will go back to its normal shape and normal function. Now, the last fellow which I want to discuss here is a bad guy. It's actually not a cellular adaptation. It's not a cellular adaptation. You are giving the stress, hypertrophy, hyperplasia, metaplasia also happened. If you are giving continuous stress, now there is a point that they have done. I am done, sir. I am done. I don't want to do any function at all. So there is total disorganization. So now in the tissue, you cannot appreciate the hypertrophy or hyperplasia. Total disorganized growth. There is no proper growth. So this disorganized tissue is called as dysplasia, which is actually a bad stage. It's precancerous stage. So first cell will try to undergo hypertrophy, hyperplasia, metaplasia. Once they are done, they will turn into dysplasia. See, first of all, this is not a cellular adaptation. Okay, it's not a cellular adaptation. It is not reversible. It is irreversible. What do you see? In the tissue, there is no proper organization, disorganized growth. So, loss of differentiation. Okay, in a normal heart or in a normal muscle, you can see a normal architecture, everything is proper. Okay, but in a tissue where there is a dysplasia, everything is haphazard, disorganized, not proper like architecture is maintained. So, there is loss of differentiation or disorganized growth. Okay, disorganized growth. Now, it's a precancerous stage. It's a precancerous stage. Okay, it is not reversible, but other things are reversible. Okay, other things are reversible, sir. So, these are the important parts which I want you to know. Dysplasia is not a cellular adaptation. Hypertrophy, hyperplasia, metaplasia are reversible. They are all cellular adaptations for stress. Now, one point, increase in the size of the cell, hypertrophy. Increase in the number of the cells, hyperplasia. In breast, hyperplasia is more. In uterus, hypertrophy is more. Stem cell reprogramming is a mechanism under, it's a mechanism under metaplasia. Okay, ubiquitin proteasome degradation pathway, atrophy is because of both decrease in the cell size as well as cell number, that is atrophy, usually seen in the thymus. For example, let me give you one more example of atrophy. See, there will be atrophy of thymus, thymic atrophy. With age, the thymus size decreases. The thymus, whatever is present in the mediastinum, the thymus size decreases. That's example of atrophy. Physiological atrophy is sometimes physiological, no doubt in that. Okay. Barrett's esophagus is a risk for adenocarcinoma of the esophagus. What is the most common side? Lower one third. Vitamin E deficiency, metaplasia. Zaskas disease, metaplasia. Myositis ossificans, metaplasia. Barrett's esophagus, metaplasia. Smoker's lung, metaplasia. So, with this, we have completed the cellular adaptations. In the next video, we will discuss about cellular accumulation, intracellular accumulations. Okay, we will discuss that in the next video. Hope the video is helpful. Thank you.